All right, so for this lecture, we will discuss all things fibrous. So in other words, fibrous tumors, and there are many different entities to know about. So we will be covering them mainly just to introduce you to the topics, and for deeper reading, I would recommend that you open the derm textbooks, the dermatology and dermatopathology textbooks, as well as other soft tissue textbooks as well. And some of the good resources out there are going to include a book called Soft Tissue Tumors of the Skin by Billings, Patel, and Buehler. I'd also recommend Whedon's pathology as well as McKee's pathology. A lot of the images from this lecture come from McKee's pathology. I gave this lecture at the Cleveland Clinic as a part of my Derm Path Fellowship, and this lecture is actually kind of produced over the years among different fellows, and we kept the slides for teaching purposes as well. So I'd like to give a big thanks to all of the past fellows at the Cleveland Clinic, as well as, my co-fellows and I, we added to this lecture the year that I gave it a couple years ago or so. So, all right, moving in to the outline. So I'm not going to read this word for word. You can pause the video and read each individual diagnosis, but just to give you a sense of the ground that we are going to cover for this lecture. Dermatofibromas and fibrous is synonymous with fibrohistiocytoma, but there are many different forms of dermatofibromas. We will also discuss things as simple as scars, but we will talk about things that may mimic scars, both clinically and histopathologically. And you can look and see on this outline that we will get to atypical fibroxanthoma, pleomorphic dermal sarcoma as well. And epithelioid sarcoma will be kind of the last topic that we discuss for this lecture. So if you want to think about benign versus malignant, you can think about malignant first, because malignant is going to include things like malignant fibrohistiocytoma, which is kind of this, it's been kind of synonymous with pleomorphic sarcoma over the years. Atypical fibroxanthoma is usually a more superficial malignant variant of a fibrous tumor. And depending on how deep it invades, how much necrosis there is, how far does it get into the sub-Q? Is there perineural invasion? Is there evidence of metastasis? Just kind of the extent of that, then you can start to classify it as a pleomorphic dermal sarcoma. But these entities are related, and there are some newer literature out there to kind of separate them out, including different mutations that may be associated with AFX versus pleomorphic dermal sarcoma. But I will say that most of it really does depend on depth of invasion and behavior of the tumor itself. Many AFXs are removed mostly on the first biopsy, and just with Mohs surgery or excision with pretty decent margins, you can get rid of all evidence of it. There's no invasion in the sub-Q, et cetera, and they have a very good prognosis. But if you have something that looks like a atypical fibroxanthoma, and then on excision, you really find yourself needing to go down deep into the fat, and there's evidence of necrosis and perineural invasion, things like that, then you need to start being worried about a pleomorphic dermal sarcoma. And as you kind of back into intermediate malignancy, you can think about entities such as plexiform fibrohistiocytic tumor, angiomatoid fibrohistiocytoma, DFSP. Again, DFSPs are pretty infiltrative and invasive, but when you compare them to entities such as epithelioid sarcoma or pleomorphic dermal sarcoma, they're borderline in terms of how dangerous they can get. Backing up to benign but locally aggressive, we think of entities like fibromatosis and cellular fibrohistiocytoma, or cellular DF, atypical DF as well. And then the benign includes everything else. So it's easier to remember the most worrisome entities, the malignant entities, before you actually need to worry about the benign stuff. So we'll start out with the benign fibrous tumors. Dermatofibroma is the most well-known fibrous tumor. It's very common. I tend to think of it as like a specialized scar, essentially. The other name for it is fibrous histiocytoma, so don't let that confuse you on exams. In fact, if someone says fibrohistiocytic proliferation, they include most of the things in this lecture, and you have to kind of first get into your mind, is it a benign fibrohistiocytic process? Is it a malignant fibrohistiocytic process? So fibrous histiocytoma and dermatofibroma are essentially the same thing. There are many different histologic subtypes. Most benign are, or most of them are benign, but the angiomatoid variant, the cellular FH variant, and the atypical FH variant can have a little bit more of a risk to spread and metastasize. Now, when we're counseling patients, if they have a cellular fibrous histiocytoma, and we're counseling clinicians from the derm path side, we'll definitely say that, look, this is going to be highly likely to recur. And so understanding that there are some dermatofibromas that are going to actually need excision with negative margins because of that small risk, versus normal DFs where you can just kind of watch it. But that being said, I mean, DFs are bothersome to patients, and so they will probably want a conservative complete excision if the surgeon is willing to do it. Now, some people consider the dermatofibroma as a benign counterpart to the DFSP, or dermatofibrosarcoma protuberans. I think that they look very different, but if you've got a really cellular variant of FH, then or a cellular variant of a DF, then it can start to really look like a DFSP. And so that's where your immunohistochemical workup can be very helpful, and we'll discuss that. So here's a clinical image of a dermatofibroma. You can see this dark brown lesion that can be mistaken for melanocytic tumors, including melanoma. So there have been many times where I've gotten rule out melanoma and it's just a dermatofibroma. So what are the key histologic features? So you see this from moderate power, this kind of ill-defined cellular proliferation within the dermis. And as you get out to the edges, you start to see a difference between the lesional and the non-lesional dermis. You can see maybe some branching extending from that central lesion. And if you go on higher power, you'll start to see areas where the collagen is kind of encircled by the fibrohistiocytic proliferation. And that's kind of what we refer to as collagen trapping. On higher power, you see a dense spindle cell proliferation of fibrohistiocytes, basically. So fibroblasts and histiocytes coming together and contributing to that lesional skin. So as a summary, what are the key histologic features? You often have epidermal hyperplasia over the top of it. So you can see that the epidermis looks pretty acanthotic. It looks like it's extending down. And so it almost looks like it's extending down as far as you would expect to see with prurigo nodularis, for example. You can have follicular induction, which means that you'll start to see areas that look like they're developing pilosebaceous unit, so little hair follicles overlying it, or more sebaceous glands. You can see sebaceous induction quite a bit. I will point out, if you do a shave biopsy and you're trying to rule out a DF, many times you'll go from where my arrow is tracing and you'll catch the superficial portion of the DF, and you'll see mostly just this acanthotic skin on top. And so depending on the clinical rule out, I may be able to catch that that's just a superficially shaved DF, or depending on if I see a good chunk of it. But oftentimes, even just seeing this acanthotic epidermis, even if you get just a sliver of fibrohistiocytic proliferation, you can say, well, it looks like a superficially sampled dermatofibroma. So for all of the clinicians out there, I would recommend doing a punch biopsy into an area that you think is a dermatofibroma, so we can get a holistic sense of what's going on. Now, this is obviously not a small punch biopsy or even a shave biopsy. This is more of an excision. It really captures the dermatofibroma holistically. We mentioned the peripheral collagen trapping. Now, it's important to note that storyform or cartwheeling growth patterns can be seen in dermatofibroma. And when you do see that, up like on the top left here, I don't blame anybody for wanting to say that that looks like a cartwheeling or storyform pattern. And so if most of it look like that, then you definitely want to rule out a DFSP. However, I would say that DFSPs mostly are even more organized, compact, and more cartwheeling than this. But both DFSP and DF don't show a lot of cellular atypia. It's kind of hard to appreciate. And so you really have to base it on architecture and immunohistochemical phenotype. So this is DF. Now, polymorphous banal infiltrate really is just referring to the fact that I said you don't see a lot of atypical cells in a DF, but even in DFSP, I've found that the cells are pretty thin, and it's hard to assess nuclear pleomorphism or cellular atypia. Now, the immunohistochemical piece of data that you're going to want is a factor 13A. A lot of people don't like factor 13A depending on what clone of antibody is being used or what lab is generating it, because it seems a little bit nonspecific. I find that CD34 is the most helpful thing, but I still do a factor 13A just to complement the CD34 stain. CD34 stains will highlight blood vessels within the dermatofibroma, but it should leave most of the neoplastic cells alone. You can see some increased staining of CD34 to the periphery of a dermatofibroma, interestingly. So if you see kind of a darker amount of staining around the periphery of the DF, but it's really light within the lesional aspect, then that's within normal limits for a CD34 stain. Conversely, factor 13A will be highlighting most of this. And as I said, it's the most important factor is it's only within the dermis. It doesn't invade into the subcutaneous fat. If you had something that looked like a DF and it was significantly invading into the subcutaneous fat, then I would worry about something more intermediate or malignant. And you would really have to take into account a correlation with excision specimen. If you're worried about it infiltrating the subcutaneous fat, then you definitely should have excision with negative margins. Just to add a little bit to the note, dermatofibromas with sebaceous induction, you can see the sebaceous glands directly connecting to the overlying epidermis, and then underneath that, you have this fibrohistiocytic proliferation. So this just happens in the setting of many DFs. And again, if you did a superficial shave of this, you might see the sebaceous induction and just a little sliver of the fibrohistiocytic neoplasm below. But again, if you are thinking that you have something like this, then you definitely need to do a deeper biopsy. You can have a dermatofibroma with basaloid proliferations as well. And so I've had many cases that look like it could be a superficial basal cell sitting on top. However, it doesn't have that clefting that you like to see many times around it. And you'll have just this peripheral palisading look to it. But then below that, you'll have the fibrohistiocytic proliferation with the whirling fibroblasts. And so I've done Burette 4 stains on these, and many times they're just completely negative. If you do see a very basaloid hyperplasia and you do a Burette 4 stain, which can highlight basal cells, and you see significant amounts of Burette 4 across that epidermis, I would note that. I would say that, although basaloid hyperplasia associated with the DF is favored here, you can sometimes have even aberrant Burette 4 expression overlying that, and it's really difficult to separate that out from a superficial basal cell. And so at the end of the day, I think that the whole thing should just be excised. And so you don't have to worry about anything becoming a basal cell being induced by the microenvironment here. So what are the other DF variants? So this is a long list, and I won't read through everything. We will highlight some with our images here, but just understand that soft tissue is a very interesting and exciting field, and also a difficult field because you can have variants of so many different common entities. So dermatofibroma, yes, that's common. And you might be able to think that something's in the dermatofibroma family, but then once you start putting in these variations on the theme, it can become pretty tricky. For example, clear cell dermatofibroma. I mean, if you see a clear cell neoplasm, there's so many other things that are going to come to your mind before you start thinking about a clear cell dermatofibroma. But that being said, if you can rule out everything else associated with clear cell neoplasms, then you're kind of left with a clear cell dermatofibroma. So a lot of this is really process of elimination based on your other differential diagnoses. If you've got myxoid proliferations, and you're definitely going to be thinking about some type of low-grade fibromyxosarcoma or even a myxofibrosarcoma, you just have to put everything into context. And sometimes it's just better to be descriptive and put your differential more than anything. But so much of this comes back onto the behavior of the neoplasm in and of itself. So you really have to look at the extent of invasion. And I recommend sending it to soft tissue specialists as well and getting their opinion on it. So we'll just briefly discuss some of the variants. Aneurysmal dermatofibroma, also known as hemosiderotic dermatofibroma or sclerosing hemangioma. The typical features include the features you would expect to see in a dermatofibroma, but you're also going to have pseudovascular spaces, a lot of hemorrhage, and a lot of hemosiderin pigment. And again, this is in your classical aneurysm DF. So here's just a picture to show you that it's a dark red papule, maybe some brown in it. You might on dermoscopy see things that make you worry about a melanocytic lesion. And so you do a biopsy and you see these dilated pseudovascular spaces. You see abundant hemosiderin. You see some areas of what look to be diffuse intradermal hemorrhage. You've got some acanthotic epidermis on top. You even got a little bit of an ulceration here. So at the end of the day, your differential diagnosis is going to include other things like vascular processes as well. And so you'll want to stain for CD31 and kind of see if most of this highlights for endothelial cells versus fibrohistiocytes. And if you've ruled out something vascular, then you're kind of left with a aneurysmal dermatofibroma. Aneurysmal dermatofibroma, again, you'll see those large vascular spaces and abundant hemosiderin in the surrounding stroma. You'll see from low power, it's pretty well circumscribed. Again, it's not really invading into the subcutaneous fat, so that's very helpful as well. Here on the top left, you can see another example of an aneurysmal fibrous histiocytoma. This is more dense compared to the other examples. So you see cellular infiltrates present in the deeper dermis, blood-filled spaces. On the bottom right, you can see another example of a fibrous histiocytoma, and the hemorrhagic spaces are pretty devoid of an endothelial lining. And so that's where you get that pseudovascular term. And so if you did a CD31 and you found that most of these were lined by endothelial cells, well, then you might be dealing with a vascular proliferation. So that can be one way to really separate it out. Now, you can stain the hemosiderin and turn it blue using a Prussian blue stain or a pearl stain, also an iron stain. It's just kind of known as the different names for the same thing. I learned it as Prussian blue, and it helps me remember that you would see hemosiderin as turning blue. This is in contrast to if you were staining melanin, it would not stain blue with a Prussian blue. It would just not stain. But if you wanted to stain melanin something, then you would pick the Fontana-Masson and stain it black. So if you're always wondering, is this melanocytic? Is this pigment melanin? And you do a Fontana-Masson or a Prussian blue to determine is it melanin or hemosiderin respectively. Looking at the histiocytic variant of a dermatofibroma, sheets of histiocytes are the predominant cell type, and you can see even areas of vacuolated cytoplasm and mixed with spindle-shaped cells. So this is kind of taking on almost that clear cell appearance, because histiocytes, more than fibroblasts, have more of an abundant clear cytoplasm. But a histiocyte is essentially just a tissue macrophage. And I think that dermatofibromas just have ratio variations of the fibroblasts to histiocytes. So in this case, the neoplasm was sending more supportive signals to grow more histiocytes as opposed to fibroblasts. And so you get a more histiocytic rich dermatofibroma. At the end of the day, It's a fibrous histiocytoma, but it's more on the histiocytoma part of the spectrum. And along those lines, this is that clear cell type. And so the cells can have very abundant clear cell cytoplasm. And again, you'd want to rule out, depending on where this was on the body in the clinical scenario, you'd want to rule out things like a clear cell melanoma or balloon cell melanoma. You'd want to think about renal cell carcinoma. You can think about other entities that can show clear cells. And you can have adnexal tumors that are abundantly made of clear cells. You can have distinct dermal tumors that are mostly clear cells. Again, this is anytime you have clear cells, it's going to bring up a wide differential. But if you rule out SOX staining or melanase staining, you rule out Paxate staining, to look for melanoma or renal cell carcinoma respectively, and you're just left with clear cells of unclear origin, then you could think along the lines of a dermatofibroma in your differential. Balloon cell type. So again, just as I said, you want to rule out entities that have balloon cells or clear cells, then that's going to bring up the possibility again of a balloon cell melanoma or a balloon cell nevus. So you want to rule out a melanocytic lesion. And if your stains are negative and you're left with just a dermatofibroma being in your differential, then that's going to be something you can include. You can do a factor 13A, but a lot of times this is going to come down to ruling out all the other stuff and the overall histopathologic picture and factor 13A positivity, et cetera. CD34 should be negative in this neoplasm. Granular cell type of dermatofibroma, unfortunately, can mimic a granular cell tumor. So you'd want to do an S100 and make sure that that's negative. Now you can have non-neural granular cell tumors to complicate the picture, but that's on your differential with the dermatofibroma granular cell type. You probably shouldn't see pustulo-ovoid bodies in this entity. Usually you'll find pustulo-ovoid bodies being in the granular cell tumors. You kind of have to take the clinical and the histopathologic together and make sure you're not dealing with a granular cell tumor. And then you'll say, okay, well, could be a DF granular cell type. Atrophic dermatofibromas are essentially what they sound like. There's some atrophy compared to the clinical surrounding where you have normal skin. You might see a kind of an invagination or a papule that's indented as opposed to raised. And so you can have an atrophic dermatofibroma that's really pulling the skin and the tissue down. It's binding it down. On histology, though, you see this hypocellular and pretty oriented parallel neoplasm. And so you can appreciate the collagen trapping. There's so many other histologic aspects to this that make you think of a fibrohistiocytoma. So you've got thick collagen bundles in between the proliferative cells. And you could do a CD34 and a factor 13A on this. But given the architecture of this and the collagen trapping, I would favor this to be dermatofibroma. And then calling it atrophic would just be kind of based on the clinical, as well as if you do see atrophy of the dermis surrounding it, et cetera. Lipidized fibrohistiocytomas, these can look pretty scary sometimes when you first identify them. They can look like there's some type of malignant proliferation or maybe some type of epithelioid neoplasm that needs to be worked up further. But oftentimes these present on the ankles of young to middle-aged patients, and they're just a non-specific kind of indurated papule, and you get this histology here that shows you these epithelioid dispindled cells with some areas of foamy histiocyte or foamy cytoplasm rather, and those are the lipidized fibrous histiocytoma cells. You can often see scattered hemosiderin throughout the lesion as well. The thing that argues for benignity here is that it's very well circumscribed. So you'll often see a predominance of these xanthoma type cells with stromal hyalinization But then once you get to the outside of the neoplasm, you just see kind of normal dermis here. So taking into account the clinical presentation, again, if you'd want to rule out other epithelioid neoplasms that, worst case scenario, you might be concerned about. So you could put on your basic melanocytic stains, your keratin stains, make sure that there's no, epithelioid sarcoma or melanoma. Any other entities that you might want to rule out will be important, and finding that most of it's negative and that your factor 13A is positive, then you can say, okay, this is just a lipidized fibrohistiocytoma. Here's another example of a lipidized or ankle-type fibrohistiocytoma. You can see the densely hyalinized collagen reminiscent of amyloid. There's a palisading variant of a fibrohistiocytoma, and it's interesting because it looks like barricade bodies here. So you might think you're dealing with some type of schwannoma, and then you drop a SOX10 on it and it's completely negative. So it's not a neural tumor. So again, a lot of the diagnosis of fibrohistiocytomas are going to come from ruling out the mimickers. So this is a palisading fibrohistiocytoma, and no one would blame you at all for thinking about a schwannoma. And this would definitely need some negative immunohistochemistry for SOX10 to be able to call it a palisading fibrohistiocytoma. Epithelioid fibrohistiocytoma. So you can see this variant presenting as a large polypoid lesion, and it's because it typically has an epidermal collarette to it. Now, seeing this clinically, anything would pop into your mind as far as malignant proliferation. I mean, even though it's symmetric, you still would want to make sure you're not dealing with a nodular melanoma or something else. So these are going to be biopsied, and from this power, you may not be able to tell what it is. It does look circumscribed and symmetric. It has this epidermal collarette where you see the end bending of reedy ridges on the side of it, just as you would see in a lobular capillary hemangioma. So you see this superficial tumor nodule. It's got that collarette, as I mentioned. And on higher power, you'll see a pretty nice proliferation of epithelioid cells. Some of them can be pretty large. They can have abundant eosinophilic cytoplasm. The infiltrate is pretty uniform, and conventional features such as that epithelioid nature of it, as well as that collarette, should make you think about an epithelioid fibrohistiocytoma. There is a special stain where you can do an immunohistochemical stain for ALK, and particularly the D5F1 variant clone. You can search for ALK in that and see that it's a positive, because many times the ALK is overexpressed in this lesion. And if you see that, then you can think about the epithelioid fibrohistiocytoma. And I will correct myself to say that it was the D5F3 clone, in particular when you're looking for the ALK overexpression in epithelioid fibrohistiocytomas. So just ordering a normal ALK may not do the trick. You might have to focus in on that D5F3 clone to really see that overexpression. You could also do molecular testing on it as well if you're worried about it. But again, that collarette, the epithelioid cells, and the symmetry and well-circumscribed nature of it, the histology, you could put that in your differential diagnosis before you have any IHC whatsoever. Here is an example of the tumor cells expressing factor 13A, but not S100. And so that would help you rule out melanocytic lesions. All right, so we've made it through the dermatofibromas. We're going to move on to myofibromas and include things like infantile myofibromatosis as well as adult myofibroma. So what is infantile myofibromatosis? It's a solitary lesion in 70%, but can often be multicentric, usually presents at or soon after birth with a predilection for the head and neck. You can see superficial localization of the disease, and that has an excellent prognosis. Visceral involvement, however, can be fatal, as would be the case with anything involving the viscera. there is a tendency towards spontaneous regression in many cases. You see these very indurated, almost skin-colored to violaceous to purple nodules and plaques underneath the skin here on a young baby. Key features include a nodularity that's well circumscribed. You may have infiltrative edges. You can see a biphasic proliferation with so-called zonation effect. Peripheral, you'll see leiomyoma-like fascicles of myofibroblasts, whereas centrally, you'll see a hemangiopericytoma-like pattern with staghorn vessels, and that may have the more primitive basophilic cells. So here you can see that central area with the more basophilic primitive cell proliferation. And then you see this very zonated appearance. You can cleanly identify the central and the peripheral locations. And again, the peripheral location is going to have the leioma-like fascicles of the myofibroblasts out here. So again, what we're looking at here is an infantile myofibromatosis. Again, this picture shows you that nodularity, how it's pretty well circumscribed with that zonation effect. More examples of the infantile myofibromatosis. You can see the myofibroma here. It's a low view power of the dermal nodule. At this magnification shown here, you can see that it's biphasic. So at the bottom left, you see a more basaloid proliferation, more hematoxylinophilic proliferation, pretty dense in terms of the nuclei number, and then it starts to separate out a little bit into more of a leioma-like fascicle. High power view here shows you the hemangiopericytomatous vascular network. So these are those staghorn vessels that you see. Anytime you see these irregular staghorn vessels, you'll definitely want to think about a solitary fibrous tumor and do a STAT6 stain, just because STAT6 are often positive in solitary fibrous tumors. But in this case, in the infantile myofibromatosis, you can make the diagnosis based on the way it appears histologically as well as the clinical scenario. But again, hemangiopericytomatous vascular network, it looks a lot like a hemangiopericytoma. So I would just do a STAT6 for completion's sake, just to see that it's negative. And if it's positive, it should be described, because you may be dealing with something more related to a solitary fibrous tumor that just has a confusing clinical scenario. Here you see infantile myofibromatosis and the tumor cells expressing smooth muscle actin. Now you can have myofibromas in adults as well. So at low power, you have this bluish chondroid hue. Anytime that someone says chondroid, it means that they've got some type of bluish hue to the background of the neoplasm. You have typically nodules that are biphasic in appearance, and the zonation that we saw in the infantile myofibroma is going to be less prominent in the adult myofibroma. So here you see the staghorn-looking vessels again. You can see some areas that look like they're forming leiomyomatous-like fascicles. And so that's your adult myofibroma. Now, when we talk about dermatomyofibroma, that's an uncommon diagnosis that often occurs in young patients, particularly women in the shoulder or axilla region. It can have a benign myofibroblastic neoplasm, and a plaque-like dermal fibromatosis is the other name for this entity. You'll often see horizontally oriented fascicles of superficial spindle cells. And the thing that I've always remembered about dermatomyofibroma is that it respects adnexal structure. So when I was first taught about this entity, the faculty member that was teaching me about it made sure that we all understood that this seems to wrap around the hair follicles. So if you think you're looking at a dermatomyofibroma, it just kind of seems like it goes to the hair follicle and then it just stops right at the hair follicle, goes around it, and then continues again. So does not displace the follicle. I find that very helpful. You see this fibroblastic proliferation going from an east-west orientation, and then all of a sudden you've got this probably anagen hair follicle. It's got some clear outer root sheath cells there. it just seems to not be bothered at all by the dermatomyofibroma, and then it continues again on the other side. So this is something that could be tested on for sure, because this is a unique feature, I would say. Other things like dermatofibromas or leiomyomas, things like that, you're not going to see the follicle so well respected. You're not going to see the adnexal structures so well respected. The sebaceous glands don't seem to be bothered very much by it either. So this is your dermatomyofibroma. Again, smooth muscle actin is going to highlight your lesional cells in a dermatomyofibroma because it's associated with smooth muscle. So smooth muscle actin. I find that Desmond is even more specific in terms of looking for muscle cell differentiation. So I often like to do Desmond in addition to smooth muscle actin. Smooth muscle actin can be present in entities even such as atypical fibroxanthomas. And so I don't find it to be that helpful when you're trying to rule out things like that, and we will discuss that. There is a disease called juvenile hyaline fibromatosis. It's extremely rare. It's an autosomal recessive disease, and it's associated with consanguinity. Hands, scalp, ears, and central face are often affected by these nodular lesions of fibromatosis. Clinically, you can see gingival hypertrophy, joint contractures, and osteopenia. The mutations associated with this entity include things like CMG2 or ANTXR2, and it has a worse prognosis compared with infantile systemic hyalinosis. Here is your juvenile hyaline fibromatosis. There's a large circumscribed ulcerating mass in this picture. There's also a smaller nodule behind the left ear. This is from one of the review books written by Dr. Hawker and Dr. Alicon. It's one of the top review books in dermatology. And you can see, I think they adapted this figure from Bologna as well. But you can see that there are many things shared by both juvenile hyaline fibromatosis and infantile systemic hyalinosis. So both of them can have cutaneous findings that they share, including firm pearly papules favoring the perinasal area and the ears, as well as verrucous perianal nodules. When you're looking at the juvenile hyaline fibromatosis, though, you'll more often see firm nodules or tumors that favor the scalp, the neck, the hands, and the trunk, whereas that seems to be less so in infantile systemic hyalinosis. In contrast, ISH is going to often have more reddish blue to brown plaques overlying the extensor surfaces of the joints and diffusely thickened skin. Both can have gingival hypertrophy, both can have joint contractures, both can have osteopenia. And when you move on to things like persistent diarrhea, recurrent infections, or visceral involvement, those three are usually going to be associated with ISH, as usually they're lacking in JHF. You can have normal mental development in both entities, but unfortunately, you will not see much survival into adulthood with the ISH. With the juvenile hyaline fibromatosis, you do see survival into adulthood. So I tend to think about things that sound worse, allowing me to kind of say, well, this is probably infantile systemic hyalinosis because it shows up earlier. They've got pretty extensive involvement. They've got diffusely thickened skin and persistent diarrhea, things that are associated with failure to thrive, including recurrent infections, and visceral involvement, obviously, is the worst prognosis. So those things will help you remember infantile systemic hyalinosis versus a juvenile hyaline fibromatosis. So in contrast to ISH, if we're looking at JHF, the key features are dermal nodular hyaline fibroma, or fibrosis and sclerosis. And you can see clusters of plump spindle cells. So you see the hyalinosis here. It almost looks chondroid in the picture on the right. and you see just the areas of linear cellularity that are interspersed in between the hyaline stroma. So if you had a biopsy showing this with the nodules and you had the clinical presentation of JHF here with all these, then you can put that together and say, okay, that's what they're asking about, or this is rare to see in real life, but if you don't know it, you won't see it. And so that's why we have to know all of these things in dermatology. All right, moving on to a scar. So we had a joke in fellowship that we would often look at things and think, oh, it could be something interesting. And then we realize, you know what? It's just a scar. So scars can be trickier than most people think sometimes. And clinically, scars can be pink papules that look like basal cells or that look like amelanotic melanomas. And it's just a scar. So, but you wouldn't know that unless you did a biopsy, and you definitely need to be prepared to be able to diagnose a scar in real life. It's more common than you think that scars are actually biopsied. Patients don't remember having trauma to the area. And just as a dermatofibroma would be biopsied, because patients may not remember they had any trauma to the area. That's the same thing with a scar. And so if you're worried about it, the patient can't explain it, and you're not entirely sure what it is, then you're going to oftentimes biopsy these things and there's just going to be a scar, but it's better knowing it's just a scar. But there are specialized variants of scars, like hypertrophic scars, that they're starting to overgrow a little bit, but not spreading the boundaries of the original scar. And then the keloid, which does overgrow the boundaries of the original scar. And keloids are excised therapeutically as well. So confirming it's a keloid as opposed to something that could mimic a keloid. Sometimes you've got some infections like lobomycosis, some weird infections that can look exactly like keloid. You can have keloidal appearing deep fungal infections. You can have keloidal appearing neoplasms of all sorts. And so confirming it's a keloid will be pretty important clinically and practically. So what are the key features of a scar? So you'll know that you're probably dealing with a scar if you see a loss of the reedy ridges. You've got this atrophic epidermis with relative blunting or loss of the reedy ridges. You've got a fibroblastic dermis. It looks like in areas sometimes even a normal looking dermis, but you'll note that the collagen does run in the east-west architecture. You'll find some areas of blood vessels which are oriented more northwest or vertically favoring more of a north-south orientation as opposed to an east-west. So if you've got vertically oriented vessels among a kind of collagenous stroma with east-west collagen bundles and an atrophic epidermis and a clear delineation on the sides of where, the scar is not present. So this is abundant solar elastosis here and has had a lifetime of exposure to the UV rays, whereas this scar does not have solar elastosis because it's relatively new. And so this is a nice picture of a scar just to illustrate some of those teaching points. Again, you're going to want to look for the effacement of the epidermal reedy pegs, the occasional subepidermal separation. And again, why does the subepidermal split happen on a scar? That's because the epidermis does not have the normal anchoring proteins that would be present within the dermis. So for example, there's no type 7 collagen anymore on top of or at the basement membrane, and you often get the clefting that happens. You need to be able to recreate all the basement membrane proteins that were damaged in that initial trauma to the cutaneous tissue before you can have true attachment. So oftentimes you'll get a cleft here in pretty fresh scars because you don't have the anchoring fibrils, type 7 collagen, the basement membrane production yet. You'll want to see the horizontally oriented fibroblasts as well as the vertically oriented blood vessels and loss of normal elastic fibers. Very nice illustration of the east and west orientation. You can see some vertical orientation of blood vessels over here to the right. The atrophic epidermis with loss of reedy ridges, also appreciated well in this picture. A hypertrophic scar is just an exuberant scar, but it does not overgrow the original boundaries of the initial scar. So you can see nodular whorled fibroblasts and blood vessels. Some have hyalinized collagen as well. So this diagnosis was a hypertrophic scar. There is the beginnings of keloidal collagen in the center of this, but what what differentiates a hypertrophic scar from the keloidal collagen is that you'll see pretty normal collagen thickness in strands, but it's going to be arranged in these fascicles, these well-delineated fascicles. And you can often get this to the periphery of a keloid. So if you just get a piece of the side of the keloid, you're going to have mostly hypertrophic scar architecture. And as you start getting more into the keloid, you'll get more of these hot pink bubblegum, very thick collagen collections, and that's your keloidal collagen. So if they're saying rule out keloid versus hypertrophic scar, I would probably look for the keloidal collagen and say it's if it has even a little bit of keloidal collagen, I would say most consistent with keloid with surrounding hypertrophic scar. But again, it's a clinical diagnosis too. So hypertrophic scar slash keloid is also acceptable because if the hypertrophic scar-like architecture is captured on histology, but it's clinically overgrowing the boundary of the original scar, then that's more of a keloidal behavior. And if you got enough sections of the tissue, you'd probably find the keloidal collagen somewhere. Moving on to like more of a purely developed keloid, that's where you're going to see the bubblegum pink amorphous keloidal collagen. So this is a really well-developed keloidal lesion here. What you should appreciate is that it's pretty sclerotic in a way. It's got so much collagen, very thick bubblegum, hot pink nature to it, but there's not a lot of fibroblast cells within this, right? So it's kind of vascularized. You've got some endothelial cells to provide some nutrition to whatever remaining keloidal fibroblasts are there. It also goes to show you, though, that the keloidal fibroblasts are probably pretty robust fibroblasts because even though it's not very cellular, they're still cranking out a ton of collagen. And in fact, we at the University of Oklahoma, our Department of Dermatology are collaborating with the Department of Surgery as well as Oklahoma Medical Research Foundation to try to learn more about what kind of dictates fibroblasts, keloidal fibroblasts to do what they do. And so our Mohs surgeons, including Dr. Collins and Hirschberg, are going to be studying and collecting the keloids and collaborating with researchers at Oklahoma Medical Research Foundation, including Dr. Olson, to really learn more about keloidal collagen fibroblasts or keloidal fibroblasts and how they make keloidal collagen. Moving on to an entity called fibrous hamartoma of infancy. So this can show up definitely on your exams and your recertification questions in both dermatology and dermatopathology. I like to think of a fibrous hamartoma of infancy as being a benign hamartoma, often in children or in infants, obviously, but it's composed of three histologic compartments or components. So you often have fat, you've got some fibrous tissue, and you have mesenchymal myxoid areas. So here you see the mesenchymal myxoid areas, the fibrous areas, and the subcutaneous fat as well. So this is, you can see that bluish color for your mesenchymal myxoid area. And you see the fibrous tissue looks more like just a fibrohistiocytic proliferation with collagen. And then your fat or your subcutaneous type tissue is surrounding this. So if you got a biopsy, a still shot image of this, and you can say fibrous hamartoma of infancy. Now, if you were looking more at that fibrohistiocytic proliferation area, you're going to just see more of this. It's kind of hard to make that snapshot diagnosis unless you've got all three entities like in this picture. But you should be able to appreciate there is this pretty cellular fibroblastic proliferation. And if you cut it on cross-section, it's going to look even more dense than if you cut it more on a longitudinal axis. Moving on to infantile digital fibroma. This is also known as inclusion body fibroma because you will often see these little small pink inclusion bodies within the infantile digital fibroma or fibromatosis. It does often extend deep and it often recurs. So here is a good example of an inclusion body fibromatosis. What are the key features? It presents on acral skin. You have dense bands of collagen and many plump spindle fibroblasts. And the key to the diagnosis, at least for testing purposes, but I've seen many cases of this in real life, you see beautifully these eosinophilic red to pink intracytoplasmic perinuclear inclusions within the spindle cells. So here you see these very beautiful red to deep pink inclusion bodies and in a background of a fibromatosis. So that's your infantile digital fibromatosis or inclusion body fibromatosis. From this power, it'd be hard to say, but if you put together the clinical presentation and then this higher power view of these very circular red droplets of inclusion bodies interspersed throughout the tissue, then you're dealing with a infantile digital fibromatosis. And this is a highly testable, high yield diagnosis to be making on dermatopathology. The next entity we will talk about is the giant cell tumor of the tendon sheath, also known as a tenosynovial giant cell tumor. It's usually on the hands. It can be benign, but unfortunately it may recur. So I'm going to move on to the clinical presentation first to show you some examples of the criteria that we're going to look for on histology and then show you the pictures. So here you see this nodule presenting as it's pretty firm nodule on the finger of a patient. And this is a giant cell tumor of tendon sheath. This is often how it presents clinically. On histology, what we're going to be looking for is a partially encapsulated lobulated neoplasm. We're going to be looking for mononuclear cells, which are considered to be synovial-like cells. We're going to look for foam cells, cholesterol clefts, hemosiderin, and of course, osteoclast-like giant cells. So that's where the name giant cell tumor of tendon sheath comes from. So you see this really well circumscribed nodule here on an acral surface. You can tell it's an acral surface because you've got very thick stratum corneum overlying that. So it's very characteristic of an acral skin. So even if they didn't tell you where this was presenting, that should be on your differential diagnosis just at this power. On higher power, you're going to see the beautiful osteoclast-like multinucleated giant cell. You'll find the background of just hemosiderin in the background, depending on if it's captured or not in the sections or, you know, in the image that you're looking at. But hemosiderin is often present within these lesions. And you're going to find several scattered histiocytic lesions, some of those monotonous or mononuclear cells that are synovial-like. So putting all that together with the clinical, you have your diagnosis as a giant cell tumor of tendon sheath. How about fibromas of tendon sheath? So it's essentially a giant cell tumor of tendon sheath without the giant cells. So maybe you got a section of tissue that didn't have the giant cells. So it's hard to call something a giant cell tumor of tendon sheath if you don't have the giant cells. But it's still at the heart of it, a benign fibroma that can recur on the fingers near the tendons. It's well circumscribed. It might be hypocellular with some bland spindle cells with dense collagenous stroma, may have some slit-like vessels. And it may be in the process of developing into a more mature giant cell tumor of tendon sheath, and you just don't have a lot of giant cells yet. So you could definitely say an evolving or resolving giant cell tumor of tendon sheath. Sometimes these neoplasms, they start to abort themselves and you don't get a fully developed neoplasm. And so it's probably related to a giant cell tumor of tendon sheath. But again, no giant cells, but it's still got that fibroma look to it. You can see some areas where it looks pretty hypocellular. You can see some areas where it looks like you've got dense collagenous hyalinized stroma. And clinically, it would be connected to the tendon. So that's where you get your fibroma of the tendon sheath. There's another entity called elastofibroma dorsi. So what you're going to look for here is it's often on the back of patients near the scapula. Women are more often affected at the age of 50 or greater. On pathology, you'll see a pretty low cellularity with abundant collagen. And what makes this an elastofibroma? So it's increased elastic fibers. So you'll see large, coarse, deeply eosinophilic elastic fibers. The reason it's called elastofibroma dorsi is because it's often on the back. So dorsal meaning, on the back side. So here you see these very dense pink fibers. Some of them look like they're becoming calcified, even on the H&E section. You could do an elastic stain and really highlight those areas of dense elastic fibers. That this is obviously thicker than what you'd expect to see in a normal elastic stain in skin. So that's going to correlate with the increased elastic fibers. They're large, they're coarse, and they're deeply eosinophilic on H&E. And then with your elastic stain or Verhoeven Van Giesen stain, you'll be able to really highlight those dense elastic fibers. Next is a sclerotic fibroma. So sclerotic fibromas are also known as storiform collagenoma. It's a benign fibroma. If you've got multiple sclerotic fibromas, you can think about an entity called Cowden disease, which is due to a P10 mutation. So here's an example of Cowden disease, and the patients can have a lot of entities associated with the development of the P10 mutation, including many trichomomas, but you can have these sclerotic fibromas. Here you see this oral cobblestoning that occurs frequently in patients with Cowden. Cowden syndrome can be remembered by associating it with that P10 mutation. They have many benign cutaneous hamartomas, like I said, trichomomas as well, the adnexal tumor that we've gone over in different discussions, and we will do an adnexal lecture to upload pretty soon. Sclerotic fibromas, as I mentioned, which we'll show an example of. The palmoplantar keratoses, which you can see here on this bottom right picture. The oral papillomatosis, which you can see on the top right picture. And unfortunately, patients with Cowden syndrome have increased risk of thyroid, breast, and endometrial carcinomas, to name a few, as well as cerebellar gangliocytomas and L'Hermite-de-Cloze syndrome. So sclerotic fibromas, what you're going to want to look for is this plywood appearance. So here's an example of plywood as a photograph, but you can see the likening to the sclerotic fibroma here because you've got this plywood-like appearance. It's almost like little slit-like spaces within a little nodule of collagen. So if you see an area that's pretty acellular and you've got these slit-like spaces and it's surrounded by the fibroblasts, just holistically as a gestalt, you should be thinking about a sclerotic fibroma here. And patients with Cowden syndrome are going to make a lot of these sclerotic fibromas. Again, just some points. You're going to want to see that it's well circumscribed, sharply demarcated. It's hypocellular with those sparse spindled fibroblasts outside of the more eosinophilic areas with the slit-like spaces. And some people have likened it to Van Gogh's Starry Night. I prefer just to be able to recognize it based on the image. Moving on to an entity called pleomorphic fibroma. These often develop in adults as flesh-colored dome-shaped papules. They can look pretty atypical because, again, you see pleomorphism. You see a cellular pleomorphism, and that can make you think that something's malignant or atypical. But this is one of those entities where even though you have pleomorphic-looking cells, it is benign. So you have to have a high degree of suspicion for it. What you're going to see is hypocellular fibrous stroma here, which you can see it's not very cellular. And then you've got these enlarged, irregularly shaped nuclei scattered throughout. So it's not very cellular, which can help remind you to think about it. It's probably a benign entity that just has pleomorphic cells scattered throughout. So pleomorphic fibromas look like this. They're hypocellular. They've got those scattered large hyperchromatic stellate cells. They're never hypercellular. If they were hypercellular, you would be thinking of something a little bit more ominous. So you wouldn't want to call something a pleomorphic fibroma if it had a very dense cellularity and it was full of all of these pleomorphic cells. You want to see it's pretty acellular, except for those scattered pleomorphic cells. And also, if you see a lot of mitotic activity as well, that wouldn't qualify for a pleomorphic fibroma. So pleomorphic fibromas, they grow, they're there, but then they stop growing. And they're, like I said, they're flesh-colored, dome-shaped papule. They're pretty well circumscribed. Interestingly, these cells are positive for CD34. So if you had a high degree of suspicion clinically and histologically that you were dealing with a pleomorphic fibroma, you could do a CD34 and highlight these cells as being positive for CD34, and that would kind of cinch your diagnosis. Normally, dermatofibromas or other variants are not going to have CD34 positive cells, so that makes this entity pretty special because you have the cellular pleomorphism scattered and you've got the CD34 positive cells. Another really good example of a pleomorphic fibroma. Again, I've seen many examples of these in real life, and they do look exactly like this. Here at the bottom left, you see how enlarged and irregularly shaped this cell is with a high homogeneous amount of basophilic staining. And then as you go through, depending on the cut of the nucleus that you've got in your section, you'll see some irregularly shaped small, medium, and large size cells. Again, the background of collagen is pretty sclerotic and it's not very cellular. On higher power, just to appreciate more of those pleomorphic cells. Irregular shape, stellate cells, again, CD34 positive. Moving on to a sclerosing perineurioma. So a perineurioma is essentially just a benign perineural tumor. These are going to be EMA positive, just like the perineural cells would be EMA positive surrounding a schwannoma. Usually the cells of a perineurioma are whorled, they're nodular, and they're storiform, but they're bland, very bland spindle cells. So if you think you're dealing with a perineurioma and you do an EMA, you're going to want to see the processes of the cell highlighting very nicely with EMA. Sclerosing variant of perineuriomas has been described, and that's where you've got a much more dense fibrostroma. So here you see this kind of whorled cellular neoplasm with some areas of more dense kind of collagenous stroma around it. And as you go on higher power, you'll see these very thin, bland spindle cells arranged with these very thin, elongated processes in between. And this is arranged in fascicles throughout. So again, if you do an EMA on this, it's going to be diffusely positive across all of these cells. And that gives you the idea that it's a perineurioma. Here's the beautiful EMA stain that you can see. So a sclerosing perineurioma, you'd still be able to see the EMA positivity is just going to have more sclerotic stroma. Moving on to angiofibroma. Angiofibromas on the face are known as fibrous papules. In tuberous sclerosis, they're known as adenoma sebaceum. On the penis, they're known as pearly-penile papules. On the vulva, they are known as vulvar or vestibular papillomatosis. If you have them in a periungual area, they are known as Conin tumors. You can often see those Conin tumors as well in tuberous sclerosis. And there's a related entity known as acquired digital fibrokeratoma, or ADFK, which can often look like an accessory digit on the finger as well. Usually with the acquired digital fibrokeratomas, you're just going to see broad collagenous stroma without neural bundles. And so that would help you kind of rule out against an accessory digit. Angiofibroma of the face, also known as fibrous papule, as I mentioned, located on the central face or most often on the nose. It's a very common diagnosis, but clinically it can look like a basal cell carcinoma. So usually you'll get the rule out of BCC versus fibrous papule versus other. If you do have multiple angiofibromas of the face, you can think about entities such as MEN1, tuberous sclerosis, and F2, for example. Here's just a nondescript pink papule in the nose. It ended up being a fibrous papule. The key features are pink fibrostroma with ectatic blood vessels and stellate fibroblasts. You can even see some displaced solar elastosis. So here you see those dilated vessels within a fibrous stroma. You can see some scattered cells. Some of them may look enlarged or a little stellate, a little atrophic epidermis on top. So this is a classic fibrous papule. More examples. Again, if you got the task to rule out a BCC and you just saw this, even on deepers, and you're pretty confident that you're dealing with just a fibrous papule or an angiofibroma. Again, I think angiofibroma is a very helpful term because it reminds you that you're going to have dilated vessels and you're going to have a fibrous stroma background. Acquired digital fibrokeratoma on adults, or typically it's on adults, but it's on the finger or toes, especially periungual. Here you see an example of a digital fibrokeratoma. Again, you'll get that rule out as rule out accessory digit because it's on the digit. And here it's pretty close to the ungual space. So someone might think about a Conan tumor, which would be an angiofibroma. But this is a digital fibrokeratoma. Here, with a digital fibrokeratoma, you'll often see it on acral skin with overlying hyperkeratosis and hypergranulosis, with corresponding epidermal hyperplasia and dense vertical collagen bundles. So this is a recognition snapshot. Even if you didn't know the clinical at all, you could still see that this is a very thick stratum corneum, suggests an acral surface. You've got this acanthotic epidermis with this kind of elongated, spiky reader ridges, and then this oriented collagen with no small nerves inside of the stroma there. So if you had scattered nerves throughout here, then you definitely have to think about an accessory digit. Also with accessory digit, you might want to see some collagen or some bone deeper down in it. But if you look throughout the entire slide and you don't see any of that, then an acquired digital fibrokeratoma is your best answer. Nodular fasciitis is a proliferation that develops in young adults, commonly on the upper extremities and the head and neck. It's of rapid onset, sometimes can be related to trauma, but it rarely recurs. So this looks pretty bad. You know, if you saw a development of something like this, you definitely would want to biopsy it and see what's going on. But many times you'll have development of things that are a little bit deeper seated into the skin, and you're not going to actually have anything very specific on clinical. So it's usually seen in the deeper soft tissues. Like I said here, it doesn't look very ulcerated or like there's a lot of superficial involvement. You'll have this well-circumscribed proliferation of cells and a spindle cell proliferation with some elongated fascicles. Looks like it's kind of situated at the lower part of the dermal subcutaneous junction. And you'll usually see it in the deeper soft tissue, but it can be occurring higher up in the dermis. You'll see areas of hypo and hypercellular, and it has this tissue growth pattern. Remember when I was discussing this with my residents and I mentioned, well, the cells are likened to be a tissue growth or a tissue culture growth like pattern, where it looks like fibroblasts growing on plastic in a dish. And they said, well, what does tissue culture like appearance look like? And I joked with him. I said, oh yeah, you didn't do a PhD in cell biology, but, and I said, good for you. But, it goes back to the fact that if you do have experience of looking at cells growing in tissue culture, particularly fibroblasts, you'll see that they kind of spread out and they've got these elongated processes, and you've got some hypocellular and some hypercellular areas. And on higher power, nodular fasciitis kind of takes on that appearance where you've got these hypercellular and hypocellular areas. You can see the extended cellular processes pretty well. But again, this is subjective, and I wouldn't really rely too much on the tissue culture appearance in and of itself to be diagnostic. I would rely on the overall circumscription, the placement within the specimen, the clinical. You'll also want to look for some areas of extravasated red blood cells, maybe some microcystic areas, chronic inflammation, particularly some surrounding lymphocytes, and it can be mitotically active, but the cells are pretty bland. And so here you can see, even in a tissue culture, to be able to grow the cells to confluency, you're going to need some cell division. And you can think about one mitotic figure here and there doesn't necessarily mean that it's a malignant process. But this can be pretty difficult because you're definitely going to want to have on your differential diagnosis many different intermediate and even malignant soft tissue tumors until you kind of work this up and study it. I would definitely do immunohistochemical stains to make sure you're not dealing with muscle-derived neoplasms, but you can definitely have positivity for SMA in nodular fasciitis, so that doesn't really help a ton. I find these to be very easy to make sure that a Desmond stain is negative. So that's always helpful, just to do a Desmond and make sure it's negative in these entities. So just more examples of these kind of areas where you have microcystic formation, more of that tissue culture-like appearance, but it's got abundant spindle cells in other areas with elongated fascicles, and it takes on a nodular appearance. So that's your nodular fasciitis. Cranial fasciitis is associated with nodular fasciitis, but it typically forms on the head of a child, usually less than 2 years of age. But the histology is the same as nodular fasciitis. It's just a clinical presentation. So if you were worried about other entities that have spindle cell proliferation, like some kind of weird myxoid DFSP or something like that, you can do CD34, make sure that's negative as well. Just an example of cranial fasciitis, taking on a pretty similar appearance with many of these tumors that we've already showed you today, with just kind of areas of hyalinized stroma, in some areas pretty acellular, other areas more densely cellular. You've got some extravasated red blood cells as well that can help you put together just a diagnostic picture here. On this one picture, it'd be difficult to say what it is, so you have to take into account the clinical, obviously. And presenting in a child less than 2 years old on the head, that's consistent with cranial fasciitis. Proliferative fasciitis is another type of variant of nodular fasciitis. It's less common and affects older age groups. On the upper trunk and the forearm is the most common presentation. And it's very rapid onset. It's always subcutaneous, but it's not super deep. Again, so that can help you think about proliferative fasciitis. It's a variant of nodular fasciitis that can contain ganglion-like giant cells and collagen trapping at the periphery. So it starts to get confusing now because you hear the word collagen trapping and you think about dermatofibromas. And all these are related to each other on a spectrum. That's why they're in the same lecture. So proliferative fasciitis, you see some areas of fibrohistiocytic proliferation with some scattered giant cells in and amongst the proliferation. So that can be a hint that you're dealing with proliferative fasciitis. Again, just some more examples of the proliferative fasciitis with some enlarged giant cell appearing lesions and even giant cell appearing cells, but even these ganglion-like giant cells, as we mentioned. So these look even more like a ganglion-like in their appearance, almost like a neural-derived giant cell. So these are pretty characteristic looking, very interesting cells. And if you see this proliferation of these ganglion-like giant cells, and it fits the whole clinical of, being on the upper trunk or forearm with a rapid onset, and it's presenting in a subcutaneous deeper area, you can think about proliferative fasciitis. Calcifying aponeurotic fibroma, also known as juvenile aponeurotic fibroma. It's present in kids on the distal extremities, such as the palm, soles, wrists, and ankles. It's benign, but 50% locally recur. More about calcifying aponeurotic fibroma. It's a fibroma with a lot of calcium. You can think of it like that. Spindle or epithelioid fibroblasts, they tend to palisade around areas of dense collagen and calcium. So you can see from this magnification here on the left side, lower magnification, some areas of very well circumscribed calcium collections surrounded by plump fibroblasts, and you can find some osteoclast-like giant cells surrounding those areas. So that's your calcifying aponeurotic fibroma. It can be biphasic, so you can see these nodular calcium deposits surrounded by those mononuclear chondrocyte-like cells, and hypocellular spindle cell component, which is kind of a fibroblastic component. Just more examples of some areas of calcification surrounded by those plump fibroblastic cells. This is your calcifying aponeurotic fibroma. There's a misspelling down here. It should be an N, not an M. All right, so now we're going to talk about benign entities, but locally aggressive. So we're going to discuss these three entities below. Starting out with fibromatosis, superficial fibromatosis includes things like Dupuytren's contracture, Peyronie's disease, as well as later host plantar fibromatosis. You have aggressive fibromatosis, which is known as a desmoid type. And it's typically benign, but it's locally infiltrative. And so if something's locally infiltrative, I actually tend to think of it as not benign, but it just goes to show you that some of these tissues or neoplasm will continue to grow into the tissue until they're removed. And there's not a lot of evidence that they can metastasize, but still, if something's locally infiltrative, like a basal cell is the same way, locally infiltrative, I don't view that as benign. I view that as malignant. So depending on the context of how it's growing clinically, I would say that's going to guide the treatment decision more than anything. If you're concerned about it on the pathology side, you should definitely voice that in your report, so that way the clinician understands that there's room for this thing to become more infiltrative and could result in worse morbidity for the patient if not excised with negative margins. Key features of fibromatosis include long fascicles of bland spindle cells. The fascicles typically run the length of the microscopic field of view. You can see here superficial fibromatosis, again, just along the same themes that we've been studying all day, where you've got these oriented parallel east to west collagen stromal architectures, and then you have scattered relatively small, relatively bland cells among it. And that's your typical fibromatosis appearance. Now, this is an even better picture because it shows you this kind of rippling, wavy architecture among the collagen bundles or within the collagen bundles. And so I like this picture because it really gives you that sense that not only is the rippling and the waving happening with the collagen, it's also happening with the cells. And so if you see something like this, you should definitely be thinking about a fibromatosis. Now, the interesting thing would be what's different about the cell biology and the molecular events with these cell types versus, like, say, a keloid or a hypertrophic scar. So there's definitely something different going on because they're arranging themselves differently. So there's more research that needs to be done to really understand the molecular activity of each one of these cells and understanding how they produce this overall arrangement of collagen and how they keep the cell to stroma ratio throughout the neoplasm, and how that ultimately affects the clinical presentation, and then being able to design treatments to try to get rid of this that might even be a little bit less surgical in nature, because trying to cut every part of the fibromatosis out is also sometimes just not clinically feasible. And that brings us to the aggressive fibromatosis or desmoid type. So the desmoid type fibromatosis is associated with Gardner syndrome. It looks histologically identical to superficial fibromatosis, but it's got an infiltrative growth and a high recurrence. And the immunohistochemical stain that's associated with this is positive beta-catenin in the nucleus. So beta-catenin nuclear staining is often associated with increased transcriptional activity of pro-fibrotic genes. And so beta-catenin is at the downstream portion of the Wnt signaling pathway, particularly the canonical Wnt signaling pathway. So this brings up the idea that perhaps these lesions have an overactivation of Wnt signaling beyond what's normally needed for normal dermal reconstruction. And so once you have overactivation of beta-catenin in these areas, and you just get this diffuse fibromatosis developing. You can actually do a beta-catenin stain here and highlight strong nuclear beta-catenin to help support your diagnosis of fibromatosis. Just as a bonus question for those of you that have studied some of the melanocytic chapters, what's another entity in the melanocytic family where you can look for nuclear beta-catenin and give you a specific subtype of a melanocytic lesion? So deep penetrating nevus is also associated with increased nuclear beta-catenin, but in melanocytes, not fibroblasts. Desmoid fibromatosis, according to the anatomic distribution, the desmoid tumors are classified into either extra-abdominal, which is around 60% of cases, abdominal, which is 20 to 25% of cases, and intra-abdominal, which is about 15% of cases. You can have plump spindled cells with rounded or tapering nuclei, showing occasional mitotic figures. So, of course, if it's infiltrative and growing, you would expect to see some mitotic figures there. It's often embedded in a hyalinized or myxoid collagenous stroma. It can infiltrate the skeletal muscle fibers, the subcutaneous fat, and the fascia. You can see peripheral collections of chronic inflammatory cells, particularly lymphocytes, which are pretty common. Here is a low-power picture of a desmoid fibromatosis showing the cellular bundles with focal collagen deposition. Again, pretty nonspecific. It'd be hard to say 100% what's going on until you get to higher power and you start to really appreciate that elongated fascicular architecture. Again, I do think that this is tough to make the diagnosis without putting together a more holistic assessment of an entire specimen. But you can see here on these examples of entities that were shown to be desmoid fibromatosis that the tumor is composed of a lot of spindle cells, variable admixture of collagen. You can see this vesicular vesicular staining pattern within the nuclei, but they have small nucleoli usually. And mitosis are commonly present as well. So seeing something like this, you definitely have to assess the entire slide, make sure you're not dealing with super highly mitotic activity, make sure you're not dealing with areas of necrosis, make sure you're not dealing with, lots of other different cell populations within it, because at the end of the day, you're going to have to entertain a whole host of different soft tissue entities in your differential diagnosis, unless the whole thing looks pretty monotonous like this, the same architecture throughout. Then you can be more confident you're dealing with a desmoid fibromatosis. Here is that example of the beta-catenin positivity, which would be another helpful way to help rule out some other differential diagnoses. So if you see beta-catenin positive staining within the fibromatosis, you can definitely think about a desmoid fibromatosis as well as just a normal fibromatosis, because that you can also see beta-catenin positivity in normal fibromatosis as well. So moving on to cellular dermatofibroma or cellular fibrohistiocytoma. These are considered benign tumors, but the problem is that local recurrence is pretty common depending on if anything is left behind inadvertently during an excision. If there was an elongated portion of the tumor that escaped margin assessment and it just had residual left behind, then you're going to have local recurrence for sure. Unfortunately, there are rare cases of documented pulmonary and lymph node metastasis. I mean, this brings up the whole idea of whether or not the original cellular DF was even truly benign in the first place, or if it was some other malignant fibrous neoplasm. But there's cases out there that say that the patient had a cellular dermatofibroma and it recurred. So when I see cellular dermatofibromas, I recommend that they get negative margins on excision. especially if the concern of the patient is that it's going to recur anyways, then we don't want one of these super rare cases to end up as another example of pulmonary and lymph node metastases. Therapy includes complete excision for sure, but also clinical follow-up. Make sure that there's no induration around the area, suggestions that it's recurring or trying to come back. The key features are that you're going to see the typical benign dermatofibroma features that we've already gone over. But you're going to see predominantly fascicular growth rather than storiform, and you're going to find a monomorphous population. You can see necrosis in 12%, and that bothers me because necrosis to me signifies more of a malignant phenotype. So if I saw necrosis, I would comment on that, and I would say, look, that's a worrisome finding. You need to get this out. Here's an example of a cellular fibrohistiocytoma, and you talk about morbidity. This picture here on the upper left is a completely just example of a morbid presentation. And so obviously it's extended broadly to the medial or to the lateral side of the first digit here. It's pretty much overgrown the epidermal lining, and it's just pushing out towards the exterior of the skin. It can be present at pretty unusual sites as well. And unfortunately, with cellular fibrohistiocytomas, children can be affected as well. This is a picture of the ulceration that happened on the forehead of a young child. And again, I mean, this does not look benign. And so even though it's considered benign in terms of its cellular features, I would say that the behavior of it is concerning. And if you excise this completely and don't have negative margins, then it's going to recur. It's just a matter of when. And so I would try to make sure you get it when it's the smallest it is and with negative margins. Here's a cellular fibrohistiocytoma. It's larger than the conventional dermatofibroma. It appears more cellular and mitotically active. So again, if you've got something large, you've got something mitotically active, it's causing morbidity. There's really no good reason to leave any of it behind clinically. So that's where we need the help of our dermatologic surgeons, and in some cases, maybe even Mohs surgery if it's on the face. We do Mohs surgery for DFSP, and this is the step below DFSP, and the fact that it could be recurrent, the fact that there's low but still present chances of it spreading somewhere else in the body, I would say get it out of the skin. Here's an example of the striking cellularity of a cellular fibrohistiocytoma. Again, you can see how cellular it is on this left-hand side. Pretty much a 1-to-1 ratio between the cell nuclei and the surrounding area of the collagen. There is mitotic activity within the bottom right-hand side here. So if you were on a microscope, it'd be easier to see that mitotic activity, but just know that these can be mitotically active at the time of initial biopsy, and on excision, you can find areas of mitoses throughout as well. This is showing that example of the CD34 staining that I mentioned before. The tumor cells at the edge of the lesion express CD34. Okay, so this is kind of what I was talking about when I mentioned looking at CD34 staining at the edge of a non-DFSP lesion and seeing that there's enhanced CD34 within that area outside of the main body of the neoplasm. So this is the main body of the neoplasm, and here's your vessels within that neoplasm. And then as you go to the edge, you'll start to see more CD34 expression before it kind of dies down. But it's a little controversial because it's unclear whether or not that represents true neoplastic cells or if it's just picking up on the stroma. But CD34 staining in a true DFSP is not confusable with this type of staining. So you really have to see CD34 staining in a benign fibrohistiocytoma before you can appreciate the difference between that and a DFSP and how the lesional cells truly do stain very positive for DFSP and a CD34 truly do stain positive for CD34 in a DFSP. Here's a cellular DF, just another example of that, but showing you that you can have some areas of necrosis here. Some good example of collagen trapping at the edge of a cellular dermatofibroma. So here, you know it's cellular because when you look at a collagen trapping area, such as here, and you look next to it, you see that the lesion is full of a lot of cells there, but the cells are pretty bland. You can find scattered mitotic figures though, and that's what makes it a cellular DF as opposed to just your normal DF. What about dermatofibroma with monster cells? So this is actually considered an atypical DF or a pseudosarcomatous DF or pseudosarcomatous FH. Histologically, you can find scattered cells that are pretty atypical. You can have some large cells with vesicular chromatin and prominent nucleoli. There's, sharing of features with regular DF, but it can look pretty scary. But again, in terms of malignant versus benign, it's considered more benign, but it's an atypical FH. And so for me, if I see these things, I comment on the margins and I say that recurrence is very likely. And, if clinically feasible or appropriate, conservative but complete excision should be considered with negative margins. So here's an atypical fibrohistiocytoma, pretty large, as you can see the small relative size of the overlying epidermis and sebaceous glands, and this is taking up the entire area. When you start to get to places like this where it extends down into the subcutaneous fat, even though it's not a DFSP, this can look a lot like honeycombing, and so it can look a little worrisome, and that's why you're going to want to work it up with the CD34. You're going to want to be able to make sure the rest of the neoplasm isn't delving down too far into the subcutaneous fat and that it's kind of still respected the subcutaneous fat. Up here, you almost have these pseudo adipocyte-like changes, and so that can become confusing too. And if you've got some areas like this, where you've got these small little pseudo adipocytes that are just like little vesicles within the tissue, little areas of fluid-filled extracellular fluid that just got removed during processing, you're left with these like little adipocytes. You can also have pseudo lipomatous changes within a lot of different neoplasms. So that can make it pretty difficult if you just got this sample to say, I'm not dealing with the DFSP, because you might think that this has completely obliterated the fat. So these can be pretty tough, and you really have to correlate with excision. The left side image is a great example of an atypical dermatofibroma, atypical FH. You have these giant monster cells, and the cells look pretty pleomorphic. Again, I think it would be tough to really say, oh, this is not a malignant lesion. When you first look at it, you really have to kind of get a sense of the monotony of the cells that are giant. And so looking to see, oh, all the giant monster cells look pretty similar to each other, and all of the smaller bland cells look pretty small and similar to each other. But there is nuclear pleomorphism by definition, and there's a mitotic figure, as you can appreciate right here in this picture. So given the pleomorphism, the mitotic activity, even though I may favor an atypical fibrohistiocytoma, and my colleagues and I may come to a consensus that it's a DF with monster cells, I'm going to describe that it's going to recur if not completely excised, and there can be more malicious infiltrated behavior if it's not completely excised with negative margins, because I think it's safer just to correlate with full excision specimen in these cases. Here you have a fibrohistiocytoma with monster cells, just a higher magnification picture showing you the enlarged pleomorphic, atypically shaped nuclei of these giant cells. Moving on to intermediate malignancy or low-grade malignant tumors, we'll discuss these entities listed below. Starting out with angiomatoid dermatofibroma, there's 4 key histologic features. You can have a thick fibrous pseudocapsule with peripheral lymphoid aggregates. So you can see some areas that look pretty dense, almost like they resemble a lymph node in a way at this low power, with multiple tumor nodules and foci of hemorrhage. So if you see the peripheral lymphoid aggregates, the pseudovascular spaces, and multinodular proliferation of eosinophilic cells, then you should be thinking about an angiomatoid dermatofibroma. The differential diagnosis, though, is also a lymph node that has a metastasis in it. So just goes to show you how lymphoid rich these cells are. I mean, these neoplasms are. So we do know a little bit about the genetics of angiomatoid fibrohistiocytoma. Not surprisingly, EWS is involved in the translocation, but EWS CREB1, which is involved with the translocation at 2 and 22, is the most common. So T222, EWS CREB1, that's what you can remember about an angiomatoid fibrohistiocytoma. There's also other EWS-associated translocations and even an FUS ATF1 translocation as listed there. Ancillary tests include Desmond. So you can do a Desmond and you'll see that it's positive in about half the cases. I do find that anything that's positive in about half the cases is just essentially like flipping a coin. So I don't know how helpful it's going to be. ALK positivity can be positive as well. And remember, ALK is also overexpressed in epithelioid fibrohistiocytomas. You can have variably nonspecific expression of EMA, CD68, CD99, and SMA. And as I mentioned above, the molecular testing, including 222, if you do the sequencing and you have a translocation panel available to you for testing, you can show that it's got a EWSR1 CREB1 fusion. So that here's that angiomatoid fibrohistiocytoma. Again, you can see these large pseudovascular spaces. Looks very rich in lymphocytes, so it's like a lymph node. You can definitely think about in your differential lymph node with metastatic cells. So you really have to understand and clinically rule out that there's no metastasis if you see something like this. It's architecturally complex and histologically complex, but if you see something that's kind of ill-defined neoplastic process that has large areas of hemorrhage and large areas of lymphoid aggregates, then you should definitely be thinking about an angiomatoid fibrohistiocytoma. And again, this is pretty rare, but it's in that intermediate malignant category or intermediate malignant category compared to the others that we've discussed so far. Another example of angiomatoid fibrohistiocytoma with lots of hemosiderin surrounding the areas of previous red blood cell extravasation. But what are some common features of fibrohistiocytic tumors of intermediate malignancy? So commonly they're in younger people, unfortunately, and they can be a cutaneous or subcutaneous lesion with a high risk of local recurrence, a low risk of distant metastasis, and lymph node metastasis as well. Moving on to plexiform fibrohistiocytic tumor. This is also known as a plexiform fibrohistiocytoma in children and young adults, commonly on the arm. Usually they have about a 40% recurrence rate and they rarely metastasize. The key features of a plexiform fibrohistiocytic tumor include a multinodular growth pattern. So it's in a plexiform or multinodular growth pattern, as you can see here. So from this power, you might even think about a plexiform neurofibroma because you see these really well separated out fascicles. So from this power, that would be under differentials, plexiform schwannoma or plexiform neurofibroma, as well as a plexiform fibrohistiocytic tumor, because you have this really well demarcated juxtaposition of fascicles, or this is that plexiform architecture, okay? So you can appreciate the plexiform multinodularity of the lesion. Histologically, it's biphasic. It's got fascicles of spindle cells with nodules of mononuclear cells. So those mononuclear histiocytic cells will typically be positive for CD68 and CD163. Those are the really two common histiocytic markers. You can see some giant cells, and then the fascicles of the spindle cells are typically going to be positive for SMA, which again, SMA is not that helpful because it's positive in so many of these different entities, but it does go to show you the biphasic nature. So here's another snapshot of a plexiform fibrohistiocytoma. It's a prototypical case where you can see the fibroblastic spindle cells in some areas, and then nodules of histiocyte-like cells as well. So very, spindly cells, and then you've got these nodules that are they've got more clear cytoplasm, which typically your histiocytes have. You can see more of the spindle cell proliferation within a plexiform fibrohistiocytic tumor. So you'd expect to see more of the SMA positivity throughout here. And then here, you would see more of the CD68 and CD163. More examples of the binary or biphasic morphology, where you've got some focal nodular collections of histiocytic cells and intermediate or interdispersed among a spindle cell population. So here's what I was talking about, that the whorly nodules of histiocyte cells would be positive for CD68 and the surrounding spindle cells would be negative. Moving on to DFSP, this is probably the most high yield neoplasm that you definitely need to know in this lecture if you're a dermatology resident or you're studying for dermatopathology. So what you're going to see are spindle cells that essentially, what we say, blow through the subcutaneous fat. So it just kind of says, I don't care, you're there. It just moves right through the fat. That's a very malignant type of behavior. You're going to see story forming. You're going to see this beautiful cartwheeling story form architecture. And then it gets to the fat and it says, I really don't care. I'm going right through you. And it leaves remnants of evidence that it did go through the fat. And so you can see down here that this is where the subcutaneous tissue used to be, but it just cartwheels its way all the way through. And that's what we talk about when we say honeycombing architecture, because it looks like this kind of honeycomb picture. To get back to some of the descriptors here, you saw the spindle cells blowing through the subcutaneous fat. You saw the monotonous story-forming hypercellular proliferative appearance, and it left behind this kind of Swiss cheese-like or honeycomb-like architecture to the sub-Q. You can see peripheral collagen trapping still, because at the end of the day, it still is a fibrohistiocytic process. The overlying epidermis is effaced with face reedy ridges on top. And that is juxtaposed, or that is contrasted to when you see the reedy ridges are more not only preserved, but even acanthotic in a regular dermatofibroma. So if you see the atrophic epidermis on top, you should be a little bit more worried about it if it's a superficial shave. And if you see a story-form pattern, you just got to shave and you see a highly dense story-form pattern, and there's no way you can say it's a normal DF. That's when you're going to have to work it up for CD34. So you staying it for CD34, it should be very diffusely positive in the lesional cells. So all these cells should be diffusely positive for CD34. And the most common translocation you need to know about is the T1722 collagen 1A1 PDGF beta translocation. This is a highly tested factoid for you for your board exams. T1722 collagen 1A1 PDGF beta. Clinically, it can look like a scar-like plaque, maybe a little bit keloidal. So as I said, if you see something growing on somebody and you're not entirely sure, is it a keloid or not, it's atypical, they don't have a tendency to keloid, then you need to biopsy this and make sure you're not dealing with a DFSP. So you can see a combination of plaques and nodules. It's pretty indurated. You can imagine how the epidermis would be pretty atrophic on top as well. And then you do a punch biopsy of this thing and you see it's pretty deep and it flows through the fat, and you're going to say, excise this, make sure the margins are negative for sure. But if you do a biopsy, just even a little bit piece of this, you should be able to stain it and get very dense CD34 throughout the neoplasm. So you see here, there's no question the CD34 is diffusely positive and strongly intensely positive throughout this neoplasm. So unfortunately, with DFSP, you can have local recurrence up to 20 to 25% of cases. If you see that histology, you're going to want to get a 2 to 3 centimeter margin excision, because that's going to lower the recurrence rate from, greater than 40% to less than 20. Now, unfortunately, 20% is still a very high recurrence rate. Mohs surgery reduces the recurrence rate to 2 to 7%. And you could do a slow Mohs as well, where you send it to the pathologist. They can look at your margins and do a CD34 stain just to make sure the lesional cells are not positive for CD34 anymore. But that's going to even increase the confidence that you got it out completely. Now, you can have very rare, less than 2% of metastasis. So I think a lot of people worry about DFSPs metastasizing. They do have a chance to metastasize, but it's more about the aggressive, infiltrative, locally destructive behavior of DFSPs that merit getting them out with wide margins. Patients that have a diagnosis of DFSP are typically worried about recurrence, and typically they're worried about them being the patients in that less than 2% category. So doing anything and everything early on to make sure that you get it out is going to be absolutely key. Histologic variants of DFSP. So DFSPs can undergo fibrosarcomatous change, where it develops a herringbone pattern to the growth. And they can actually lose a little bit of their CD34 staining adjacent to the rest of the DFSP. So it becomes tricky, because you really have to look for the herringbone architecture as well as loss of CD34 to say that you have fibrosarcomatous change within the dermatofibrosarcoma protuberans. You can have myeloid or myofibroblastic changes, myxoid changes, granular cell changes. Every intermediate listed here, or every variant listed here, you could have, but most often you're going to find just your traditional DFSP with maybe fibrosarcomatous change, and that's where you really have to look at these features that we will discuss in the next couple slides. Before I get into that, if you have a lot of pigmented cells within a DFSP, that's called a Bednar tumor. But essentially, besides that pigment, everything else is identical to a DFSP. Showing you a myxoid DFSP. So if you have a very light kind of stroma that looks like it's got abundant mucin, stringy blue material with these little punctate textures along the string, that's myxoid. That's mucin. And so if you've got a myxoid DFSP, you're going to look for CD34 positivity among that, because it can be pretty difficult. And on the bottom right, you can see a high power view from a different case of myxoid DFSP, even showing a complete loss of storiform growth pattern. So that's tough, and you'd really have to stain for CD34 and show most of those cells are positive. So in a lot of these entities, I do CD34 just to make sure I'm not dealing with some weird variant of a DFSP. And it may not be 100% possible to classify it by yourself. You may want to send it out and get second opinions. You may want to do some molecular testing on it. Again, you might be able to find a translocation like the T1722 collagen 1A1 PDGF beta, just to kind of see, is it behaving more like a DFSP versus just your traditional myxoid variant of any other fibroblastic proliferation. Giant cell fibroblastomas are interesting. They're basically a juvenile variant of DFSP, and they're going to be expected to have the same immunohistochemical findings and molecular findings of DFSP. So if you find a DFSP that has giant cells in it, that's because there is a variant of giant cell fibroblastoma, which has the same molecular events happening within it. But usually if it's in a juvenile patient, then it's going to be just the variant of DFSP, giant cell fibroblastoma. You can find multinucleated giant cells around pseudovascular spaces. Unfortunately, there's a pretty high recurrence rate locally of 50%. And at the time that this lecture was made, there was no metastases. However, there could be some new reports out there. Giant cell fibroblastoma, you can see these large giant cells interspersed among this highly collagenous stroma. Again, nothing about this tells you storiform or anything cartwheeling related, but it's essentially the same molecular underpinnings as a DFSP, interestingly. So you'll see areas that look like a fibroblastoma because you see this wavy collagen in the background, and then these giant cells. Another example of a giant cell fibroblastoma, an intermediate power. So you see more giant cells spread across the tumor with this fibromatosis background. Giant cell fibroblastoma. So again, I think what could be helpful here is just seeing that you have a pretty high ratio of the cells being classified as giant cells, and then you've got that fibroblastic stromal proliferation in the background. And I would probably consider doing a CD34 on this right off the bat to show that, yes, it's positive for CD34, because again, that's going to be very similar to DFSP. And then maybe also sequencing it just to see if you do have a translocation in the background. All right, moving on to malignant fibrous tumors. Start out with the fibrosarcoma. So I did mention fibrosarcoma is change that can develop within a DFSP. This is a deep soft tissue sarcoma. Most of the times I've seen DFSP has not had fibrosarcomas change, but if it does have fibrosarcomas change, what you're going to look for is a newly rapidly growing nodule in a pre-existing DFSP. And I'll show you the herringbone pattern just kind of right off the bat. It's a very beautiful pattern in histology where you see this is the herringbone design on the bottom right. And you see these fascicles that, depending on the cut and cross section, are going to be alternatively oriented to each other. So you've got elongation and you've got cross section, elongation longitudinally, and then more cross section again. And it's just oriented in a very organized way. And if you did a CD34 on this, it'll actually be a lot lighter in staining than the original DFSP, which would have more of that storiform cartwheeling growth pattern, and it's going to be more rich in CD34. So if you pair this pattern with a decreased CD34 expression next to a DFSP or in an area where there used to be a DFSP, then you can think about fibrosarcomas change associated with DFSP. Moving on back to the factoids. So these are uncommon, 5 to 16% fibrosarcomas change in a DFSP. It often presents as a newly rapidly growing nodule in a pre-existing DFSP. The diagnostic criteria include making sure that it's about 5 to 10% of the tumor with vesicular growth pattern, rather, increased mitotic activity, greater cytologic atypia, and often diminished CD34 expression, as I mentioned. Other key features: densely cellular spindle cell tumor with that herringbone pattern. You can see necrosis and mitosis as expected with any malignant transformation. Nuclei may be large and hyperchromatic. So for me, I think of fibrosarcomas transformation as something bad within something bad, something worse within something bad, because DFSP is already bad, but then if you got fibrosarcomas change, that's worse. Moving on to atypical fibroxanthoma. These occur in the elderly, often on the head and neck and sun-exposed areas. It's they can occur on the ears. They can occur, mostly you're going to see them on the scalp, but head and neck, anywhere on the head and neck, they're very common. They're going to present as ulceration, as bleeding, as neoplasms that are growing quite large pretty rapidly. And your concerns are always going to be melanoma, squamous cell carcinoma, some type of leiomyosarcoma. These are all things to consider. Nodular angiosarcoma. So anything that's presenting on the scalp of an elderly person that's growing abnormally like that is going to be biopsied. And here's an example of that clinical. So the scalp, very common site. These are going to be very bloody when they come in. The patient's going to say they've grown rapidly. And atypical fibroxanthoma is a diagnosis of exclusion clinically and histologically. So we really have to exclude everything else before we can call it. It's an atypical pleomorphic spindle cell tumor. It has broad nodular-like growth. It has an ulceration on top. When you go in higher power, you're going to see very atypical cells. It's highly dense, highly pleomorphic, scattered mitotic figures. And your differential diagnosis looking at this is going to be a poorly differentiated squamous cell carcinoma, a leiomyosarcoma, an angiosarcoma, a melanoma, everything's in play. And you have to do the immunohistochemistry to be able to rule out everything else. Once everything is negative, then you can come back and say, well, it's an abnormal or atypical epithelial to spindle cell proliferation consistent with atypical fibroxanthoma, depending on its level of invasion and its behavior. If it goes down deep into the subcutaneous fat and there's areas of necrosis and it's more infiltrative, then you're dealing more with a pleomorphic dermal sarcoma. There are some genetic separations between atypical fibroxanthoma and pleomorphic dermal sarcoma, but at the end of the day, it comes down to really the infiltrative growth pattern. Your differential diagnosis includes spindle cell or sarcomatoid squamous cell carcinoma. As I mentioned, those are typically going to be positive for keratin, spindle cell, squamous cell carcinoma, but sometimes they're so poorly differentiated they don't make keratins. I would do a low molecular weight and a high molecular weight keratin because some of the poorly differentiated sarcomatoid squamous cell carcinomas do not express, every type of keratin, and some actually don't express keratins at all. So a P63 should be positive in the poorly undifferentiated spindle cell squamous cell carcinomas. AFXs should be negative for P63, so it's very important to know that. I'm pretty sure that there's AFXs out there that were poorly differentiated spindle cell squames that were P63 positive, but it just wasn't thought to test for the P63, so they were called AFXs. Leiomyosarcoma, so you'll want to do SMA and Desmond stains to rule that out. If they're negative, then you're still entertaining AFX. Angiosarcoma, you'll want to do a CD31, CD34, or an ERG. Either of those are acceptable, although I find that ERG is the most commonly used. It's pretty sensitive and it highlights endothelial-derived cells, even poorly differentiated endothelial cells, quite well. Melanoma, so you'll want to do your SOX10 stain and you'll want to do your melanase stains as well, but definitely a melanocytic marker. And I will say that PRAME is positive in melanomas. But in the spindle cell variant of melanoma, the PRAME stain is usually positive in only 30 to 50%, depending on the paper that you read. However, keep in mind that PRAME is a marker of malignant behavior. So that is currently being studied quite closely. Immunohistochemistry-wise, cytokeratin, S100 or SOX10, Desmond, ERG, I've already mentioned these. These should all be negative in atypical fibroxanthoma. Now, what's the immunohistochemistry that's most commonly associated with an atypical fibroxanthoma? CD10. So CD10 has been found to be positive in atypical fibroxanthomas, but the other thing is it can be positive in sarcomatoid squamous cell carcinomas, and CD10 is kind of a non-specific stromal marker. So it does stain AFXs, but you shouldn't rely on CD10 positivity to make the diagnosis. And in fact, CD10 can be positive in half of sarcomatoid squamous cell carcinomas. So what that means is that you're going to need to do something else besides CD10 to tell you it's an AFX versus a sarcomatoid squamous cell carcinoma. So you need to do the P63 and both low and high molecular weight keratins to truly rule that out. AFXs can be positive for SMA as well. So again, that's where your Desmond is going to come into play, because if you have a SMA positive neoplasm, it doesn't mean that it's not an AFX. It doesn't mean that it's a leiomyosarcoma. It just means that the SMA is positive in the AFX. And so you would want to do a Desmond and show that's negative before you call atypical fibroxanthoma. If you have diffuse Desmond positivity, then you might be dealing more with a rhabdo-differentiated sarcoma, some type of rhabdomyosarcoma or a leiomyosarcoma or something of that nature. But there are variants of atypical fibroxanthoma, so you can have a spindle cell variant, obviously, clear cell variant, osteoid or osteoclastic variants, chondroid variants, pigmented variants, and granular cell variants. Again, variants are just to show you how diverse biology is and how diverse pathology is. But at the end of the day, that's going to be extremely difficult to make those diagnoses. What you're going to see more commonly are your traditional bread and butter atypical fibroxanthomas. Once you start getting into these variants, I would say that you definitely want to get a consensus before you try to call something, granular cell atypical fibroxanthoma, for example. But again, if you won't see it unless you know it, so you should be aware that there are variants out there that have been described. What people are mentioning when they say pleomorphic spindle cell neoplasms. So you can sign something out as a pleomorphic spindle cell neoplasm descriptively, but you could be dealing with an AFX. You could be dealing with a pleomorphic dermal sarcoma. Pleomorphic dermal sarcomas are oftentimes kind of thought of as a malignant fibrous histiocytoma. There's been different names in the past. And so, typically, if you think about a malignant fibrous histiocytoma and you try to differentiate that from AFX or pleomorphic dermal sarcoma in terms of the cell type, the lesional cell, it can be pretty difficult, pretty challenging. So like I said, it really all comes down to behavior of the lesion, extent of invasion. And until we truly identify markers that separate AFX from pleomorphic dermal sarcoma, AFX versus something that behaves even worse than an AFX, until we discover those biomarkers and those factors, we have to rely on how it's behaving currently at the excision time. So if it's greater than 2 centimeters and extensively involves the subcutis, if it penetrates into the fascia and the muscle and displays necrosis as well as vascular invasion, then you're dealing more with a pleomorphic dermal sarcoma as opposed to just simply an atypical fibroxanthoma. The reason why on superficial biopsies of the initial biopsy, the pathologist cannot tell you it's a pleomorphic dermal sarcoma is because we're not usually assessing the subcutaneous tissue at that point. So it could be a pleomorphic dermal sarcoma, but it could just be an AFX, and you won't know until you actually get the excision. So you need to excise it. And that makes it tricky for the Mohs surgeons because these Mohs surgeons oftentimes are not going to know how far they have to go down into the subQ. And so they may be dealing with something way more extensive than what they realized that they were trying to get out from the patient. But again, you don't really know what you have until you excise it out. And so that's kind of a big teaching point with these things. There are some current research studies going on where we could try to determine, maybe using even immunohistochemistry, whether or not we're dealing with probably just an AFX or probably a pleomorphic dermal sarcoma, even on that superficial biopsy. But those studies are ongoing. So pleomorphic dermal sarcoma, also known as an undifferentiated pleomorphic sarcoma, histologically very atypical and pleomorphic, just as an AFX. The IHC does not reveal a specific lineage of the tumor. That's what I said. It's negative for almost everything. CD10 doesn't tell you anything specific about the lineage of the cell. And so, there's going to be a lot more research coming out separating AFX versus PDS. And it's going to be very interesting and highly impactful to this patient population. It's a super common diagnosis, actually, and I see it all the time. Epithelioid sarcomas develop often on the distal extremities. They can be seen in children, unfortunately. Technically, the cell of origin is not clear. However, you can see on histology that you're dealing mostly with an epithelioid neoplasm. There is a proximal type of epithelioid sarcoma as well as a distal type. You can see the morbidity associated with epithelioid sarcoma. So if you see this ulcerative neoplasm on the distal portions of the patient, you can definitely always include epithelioid sarcoma in your differential. Unfortunately, it spreads along neurovascular bundles and fascial planes, and it results in deposits of the tumor more proximally, as seen in this patient. So here is the histology of an epithelioid sarcoma. Again, at this power, you're not going to really know what you're dealing with. It's just some type of epithelioid neoplasm. At low power, it could even look like a palisaded granuloma. So we're talking about things like granuloma annulare. It's often biphasic, epithelioid and spindle cell population with central necrosis. So again, you can kind of see this necrotic area down in here. Positive for AE13, which is like a pan-keratin cocktail. EMA and Vimentin. I will advise that Vimentin is not that helpful. It just stains a lot of things. And so I don't really ever use Vimentin. CD34 is positive in about half the cases. Most importantly, though, INI1 is lost in the nucleus of epithelioid sarcomas in about 90%. So if you think you're dealing with an epithelioid sarcoma, it's going to be important to first stain for keratins, stain for CD34, and also INI1. If you see INI1 is lost in lesional cells, that's a very worrisome finding. The other thing is you're gonna be able to observe that it's gonna grow and you're gonna have larger areas of necrosis. It's not gonna be behaving like a normal palisaded granuloma type process like GA or even a rheumatoid nodule for that matter. But those are histiocytes in those entities. So you could stain for CD63 and CD68 rather, and CD163 just to highlight histiocytes and make sure you're not dealing with epithelioid sarcoma. But it comes down to looking at the cells, looking at the overall architecture, looking at the extent of growth. And the INI1, I would say, is key. You probably shouldn't sign on an epithelioid sarcoma unless you've done all of these stains here, at least the keratin, CD34, and INI1. There's been times where people have tried to work up epithelioid sarcoma compared to other types of sarcomas, and they found INI1 was diffusely positive, and so that made them feel very strongly that they're not dealing with an epithelioid sarcoma because it's so statistically likely to have loss of INI1 in the nucleus of epithelioid sarcomas. Here's that example of the palisading of the neoplastic cells around this kind of necrotic, or even some might just say relatively smudgy looking collagen. You may not even feel that it's very necrotic. You may feel that it's just necrobiotic, like how you would see in granuloma annulare. But on higher power, when you inspect these cells, you'll see these cells are epithelioid, they're pleomorphic, they've got mitotic figures. So if you did an INI1 stain here, then you should see diffuse loss of INI1. You should also see expression of some keratins and maybe some CD34 as well. All right, well, that's all I have for this lecture slide set. So good luck in delving deeper into these topics and the textbooks, and practice questions that you do have. And just review this for the key concepts and introductory material before you delve into some of the literature, which can be even more revealing.